Hello, my name is Martin Lipscomb and I'm joined today by Associate Professor and Associate Director of Infrastructure and Technology, Bernie Garrett. Bernie works at the University of British Columbia in Canada. He's a prodigious paper writer and book author. He is, for example, sole author of Fluids and Electrolytes, Essentials for Clinical Practice, which is now in its second edition, Science and Modern Thought in Nursing, Pragmatism and Praxis for Evidence-Based Practice, and Empirical Nursing, the Art of Evidence-Based Care. Moreover, together with Paul On and Paul Goldus, he is responsible for the Pocket Clinical Reference for Nurses, and that's now in its fourth edition. Bernie's scholarly concerns fall broadly into two main camps. First, he seeks to expose deception and skullduggery in alternative medicine and the ill-conceived products and services that pass themselves off illegitimately as being evidence or research-based. Second, as his job title might suggest, he's interested in the use of virtual and augmented reality technologies in healthcare applications, such as those concerned with pain management. Today, Bernie has agreed to discuss just a few of the arguments presented in his book, Empirical Nursing, the Art of Evidence-Based Care. Bernie, would you like to describe the book? What is it that you wanted to convey or say in this work?
Hi, well, thanks for your interest in my work. Yeah, basically this book was something that arose out of a bit of a passion for science that I've had over the years and its application in nursing. Particularly, I mean, I come from a European nursing tradition, which is very pragmatically based, trained and worked in the UK as a renal nurse specialist for a number of years, and then moved to the North America, to Canada, and I was particularly struck by there is a very dominant trend in postmodern aspects of nursing, and I was really interested in how that came to be and the arguments to support that, but also to provide a counter argument to some of that and explain some of those principles, why these arguments have arisen, and really why I believe that a science-based empirical approach in nursing is something we should strive for and try and achieve in nursing for the future of the profession.
Okay. The book is comprehensive and it's also well worth reading, but I'd like to ask you a couple of questions about the arguments that you present in the book. And my questions can only begin to scratch the surface of, or not even that, of the range of subjects that you cover. However, you begin the work with a quote from Bertrand Russell, and this says, "The art of basing convictions on evidence and of giving them only that degree of certainty which the evidence warrants would, if it became general, cure most of the ills from which this world is suffering." End of quote. Now, this is perhaps a disputable claim. It captures, for example, a version of evidentialism that not everyone can buy into. Nonetheless, in nursing, we're willing, for laudable reasons, to grant the title evidence to research findings that derive from radically different methods and methodologies. And indeed, on page 135 of your book, you allow that expert opinion can be classed as evidence. Now, many nursing methodologists suggest or allow that qualitative and quantitative research are, depending on the question or problem being investigated, of equal value or importance. That is, qualitative and quantitative research findings are, for many people, equal forms of evidence. What do you think? Is this the case? Or, while all forms of research can potentially add to understanding, given that nurses turn to research to inform their concrete practice, is there a case for prioritising those forms of research, those forms of evidence that crudely are associated with generalisation? And I suppose I am here inviting you to differentiate between research and evidence. I'm inviting you to allow that a research finding, although defensible, need not be considered evidence.
There's a lot wrapped up in that question.
Yes.
Yeah, I'm happy to respond to that. I mean, I love Bertrand Russell. I mean, he's so tongue-in-cheek with a lot of what his quotes. I use his quotes quite a lot as analytic philosophy goes. I think he really poses some of these key issues very nicely for us. So to that question, I think really, if we look at that, this debate that is very often contextualized as the quantitative versus qualitative in nursing has been going on, well, for at least the last 50 years. And I think it's a very interesting one if we look at, what is the value of evidence and how does it inform nursing research in terms of sort of outcomes of qualitative, and how do we balance that with quantitative work? But my take on this is very sort of pragmatic, really, as I am a pragmatist at heart, in that really I'd regard them as pretty much the same thing, unless you're taking a completely postmodern philosophical perspective. And my argument here would be the purpose really of nursing research for us, and the main value of it, is we're practitioners. We do things that improve people's health status or in their lives with regard to health. That's pretty much a goal of what we're trying to achieve. So it's a practical goal. So in that case, in that sense, I'd suggest that the purpose for us of research is to be able to have research that we can use, which may involve generalization, and then apply in specific instances, which may be at individual levels, which may involve individual expertise as we apply that knowledge, because, for example, it might not work in every case. So some degree of generalization is of value to us in research, and any type of research that enables us to understand a phenomenon better and be able to generalize how the phenomenon occurs, what relates to it, how it happens, and then to be able to interpret that at an individual level is of value to nursing. Now, going back to the qualitative and quantitative piece, I mean, this is the fundamental argument, I think, behind a lot of the criticism of evidence-based practice, particularly from the evidence-based medicine movement, the notorious pyramid that causes so much concern of people with a pyramid of evidence, which quantitative is obviously ranked higher. But the problem I have with some of this is when you fundamentally look at it, and I've done both qualitative and quantitative research, as I know you have as well. But if we look at when you're undertaking quantitative research, you're really counting things. You're obviously looking at statistics of instance, and looking at correlations, various other statistical techniques we can use. If we look at qualitative research, the majority of what we're doing is observing instances, usually through textual analysis or analysis of individuals' observation, those sorts of things. But fundamentally, the process in a lot of qualitative research is looking for repeated instances or patterns. If you're doing that, it's you're in some way, although you may not be quantifying it with actual numbers, you are still looking for similarities. And in that instance, I'd argue it's very much the same thing, unless, of course, as I say, you're taking a postmodern approach in which you're just assuming everything is equally valid, and you can, this is just one description of one event at one time, which is equally valid as something else. So my argument for that is that they're both of value. I would still argue that numerical sort of research does have slightly higher sort of, if you like, I'm reluctant to say of higher value than qualitative, because that always gets you in hot water. But it does have more predictive, if we can quantify things, that does help us more in predictive outcomes from research. But that doesn't mean it's more important, but they're equally important in the process, because you have to start off with the descriptive stuff before you can move on in many cases to the sort of analytical causal quantitative research. So I think it's a very thorny question, but and I think it's loaded as well because of the politics of most nurses do engage in qualitative research. There's more of that undertaken than quantitative research in nursing. So the profession is very much bound up with that, as it should be. But I think if you're looking at the term of practice, then they both have an important role to play. And really, at the end of the day, there is more similarities between qualitative and quantitative research than there are differences.
Okay. I suppose my question was inviting you there to step into a hot place. Let me ask you another very long, slightly windy question that again invites you to step into a hot place. You make an interesting and possibly important observation with regard to theory, when you state on page 78 of your book that, and here I quote, "Theories are empirically adequate if they correspond to observational events in the past, present, and future. Theories that describe or involve unobservable events are considered not as true, but as empirically adequate as long as they remain uncontested by confounding data," end of quote. Now, if, for the sake of argument, we accept this statement as given, what follows on from this for nursing? This seems at face value to place many of our findings in the adequate rather than the true category. Thus, for a great deal of the research conducted by nurses deals or is concerned with unobservable events, if by observable we mean directly observable. So, for example, research into burnout or emotional intelligence or compassion can only observe the objects of investigation indirectly. Observation of these and kindred concepts and kindred events relies on interpretation, perhaps the interpretation of participant statements or the interpretation of, in the case of burnout, the number of nurses retiring ahead of retirement age. Now, of course, all observation involves interpretation. However, the examples I've just described, examples concerning humans and human interaction, require forms of interpretation that are more extensive or are different in kind from those associated with the physical and mathematical sciences. Does the definition of theory that you present threaten the strength of claims that attach to many nurse research findings?
Yeah, and again, this links very well to the previous discussion that we just had. I mean, again, empirical advocacy, I think, is the best we can hope for as humans interacting with research. And we are part of the process. So inevitably, we affect the process, and our own perceptions of the value are bound up with that. And it speaks again to this great divide between that's been discussed about, social science research on the one hand and physical sciences on the other hand, never the two shall meet, and they're going in different directions. But again, I'd argue that they're both less actually divided now than probably they have been for a long time. Human science is fundamentally about explaining behaviors of peoples and groups and identifying aspects of those that we can improve people's lives with. In nursing, as I say, I come back to our focus is on healthy behaviors and health. So when we look at what type of research is being undertaken in nursing, I think a lot of it is at the descriptive level, certainly in North America, maybe less so in Europe. I'm not sure that's the case in Europe so much, but certainly there is a lot of descriptive research on part of nursing. And it's still important to understand why things are happening to people, or why certain occurrences happen, or how people feel about things. Those are important for us as nurses to understand. But inevitably, those things only really have value to us as nursing if we can apply them in other practice settings. So that requires us to undertake some empirical sort of work to form some sort of idea of how best we apply that knowledge in practice. Otherwise, we just end up in a simple circle, which I've seen a lot in nursing education, of inevitably describing phenomena. And there's loads of papers out there, and there's PhD pieces on this, where people are just describing a phenomena, and then that's it. They move on to something else, or they describe another phenomena. And that's interesting, but it becomes very theoretical then, and it doesn't become a practical value to the tool of the working nurse. And this is the thing that I always come back to, is that everything we do should inform practice and improve practice, so that we're continually getting better at what we do. So in terms of empirical adequacy, yeah, a lot of the things we involve with human interaction and with human behaviors are, we can fundamentally look at the context they're occurring in and come up with some form of description and predictive models of that, but they're only ever going to apply in certain circumstances, particularly. So they are empirically adequate, and that if they work for us, going back to the pragmatism argument again, there's nothing wrong with that in my mind. That's useful. They may work now, they may not work in 50 years' time when things have changed, cultures have changed, human behaviours have changed. We're seeing that at the moment with pandemic behaviours. So it's important that we bear that in mind, and that's why this research needs to be ongoing. But at the same time, even in physics and other research, we find some of the research findings there, they're empirically adequate because they work to describe phenomena. They do get overthrown, as we have examples, you know, from the Ptolemy's revolutions and in physics to modern quantum physics, where things we think we understand in terms of Newtonian mechanics are now changing completely with quantum, our understanding of quantum theory. So I don't think empirical adequacy is just related to human science. I'd say it relates to all aspects of science. And again, I think the important thing for us to do is strive to look at research that actually has value in its application, rather than research that is going to be interesting and may provide some insights into, you know, a very narrow specific field, but may not really have a huge amount of sort of mileage in terms of improving practice in the future.
Okay. Let me ask you a different type of question. With regard to the hierarchy of evidence, or the method pyramid that you mentioned earlier, you are a tad, I think, dismissive in rebuking those critical of systematic reviews. You note that such dismissals emanate from those with, you state, vested interests. However, valid criticisms of this sort of evidence do exist, and these criticisms focus, as far as I can tell, on questions of overreach. That is, while the claims made for these reviews certainly have epistemic warrant, they're really interesting, clinicians must remember that in their construction, difference is generally obliterated, and perhaps differences in who is recruited, or differences around the range of comorbidities allowed among recruits, can be important. Indeed, while the internal validity of a single RCT, the single unit of study generally co-opted into a systematic review, can be high, its external validity can be poor. And when these types of study are agglomerated, arguably, external validity is further degraded. Now, is that a fair criticism? I don't think I've got a vested interest here.
I think that's a fair criticism. And again, I think there are significant criticisms that are valid of any type of research. All research has flaws. No research is perfect, and systematic reviews have certainly got some considerable issues with them. I think going back to systematic reviews, I mean, they've only really been around for 50 years now, possibly less than that. So they're a relatively new sort of big data approach to research, but they also have significant power. And we know this because, I mean, if we look at the original one that's cited in Cochrane, the Crowley, Chalmers and Kearse study of steroids in infants, it gives a good example of the power. When you do have good data, you can actually find some interesting things by expanding beyond single studies. The problem with them is, and this is made by, obviously I accept, and this is a criticism being made by a lot of people, is it's the same basic principle as garbage in, garbage out. If you take bad data into a systematic review and then you analyze it, you can come out with just about whatever results you want, you know, by selecting which studies you put in, and you know, studies that bias particular populations. And we know that happens with some RCTs and things like that. So I think it is a fair criticism to say systematic reviews do have issues with external validity, but we're getting better at identifying those problems. That's just the thing. I think if we look at the criticism of evidence-based practice, and particularly the evidence pyramid and systematic reviews, those meta studies at the top of the pyramid, where they were 10 years ago is not where the tools they were using there are not the same as the tools used now. If you look at some of the early Cochrane reviews, they're terrible. Some of them are really bad. Some are great, but some are actually bad and have been withdrawn. And so, you know, the evidence is there that we're actually getting better at this. There are now new tools to actually look at validity, and particularly, you know, looking at which studies are included, indicators of how effective they are. There's some very powerful statistical techniques that are being applied now. And there's people like the Evidence-Based Medicine Centre in Oxford with Professor David Nunnan, who are looking at, you know, techniques to improve evidence-based practice. And there's more in the medical side, I appreciate, but at the same time, though that work is going on. So we do now have some better ways of actually looking at what's going into systematic reviews and how valid that, you know, data is in terms of particularly as external validity, as you pointed out. I think the issue is scrutiny in research. It's quite a high level skill to achieve, and this is why we need more higher educated, advanced nurses with advanced practice skills and advanced knowledge of understanding of research, because when we start to get into analysing research and using things like systematic reviews, you do need quite a high level of skill to do that effectively. We're getting, as I say, I think we're getting better at it. That doesn't mean that all systematic reviews are, you know, suspect, but it means we have to treat them with a degree of skepticism, same as any other research. And this comes back to a basic principle of science, which I keep reiterating, and so you raised it in the question there, is what does one study tell us? Well, it doesn't tell us anything. It just tells us in one particular instance, we have found this result. And this is why we need repeat studies. We need to do studies in different contexts, different populations, to see if the same outcomes apply, and which is why research is so important, and for why nurses engaging in research is important. The more studies we do, the more likely we are to find out if something is actually a valid pattern and can help us inform our practice in the future. But unfortunately, we don't see a lot of that. We see a lot of descriptive studies that look in a very narrow single population in nursing, and then publish and then go and do something else completely different. You know, there's very little repeat studies. And that, again, working with my other hat on looking at deception, a lot of deceptive practice relies on that. They'll cherry pick particular studies to make an argument that haven't got good replicability, and then use that to justify selling a particular product or service. So yeah, I think having sort of, for me, having nurses have good understanding of sort of all aspects of research, but be able to critique research, including systematic reviews, is an important skill. And I would agree with you that, you know, I've covered this stuff very briefly in the book, and I could expand on that. And of course, it's a couple of years old now, so some of these tools that of assessing systematic studies weren't around when I wrote it. But I think that's a fair criticism.
Bernie, it's great talking to you. And I just, as I mentioned, when I read your book, I scribbled all over it, which is for me a sign of a very interesting read. I'd heartily recommend the book, and indeed all of your writings, to anybody who wanted to investigate evidence-based nursing, evidence-based practice more. Let's round it up there. It's been great talking to you, Bernie.
Thanks very much, Martin. Take care.